Good morning and welcome to our monthly webcast. I am your moderator. This is session number 81. We have a genuinely complex calcified bifurcating distal left main which will take you through. Hopefully you'll learn many tips and tricks of the trade. Let me take you straight to the Cardiac Cath lab where Dr. Kinney and Dr. Sharma are standing by. Samin, good morning.
All right, good morning from our Cath lab team of Mount Sinai to our webcast, and clearly we have very interesting case.
Very excellent choice, I think, to show.
Yes, and I think knowing that we are already slightly late here because some logistics, we just want to start right, get into the case with our supporters, the disclosures, no change, and this is the 80-year-old male with the long-standing history of angina, and he had an intervention 7-8 years ago here of the RCA, but then he recently presented with unstable angina class 4 outside hospital, ruled out for MI, and cath revealed 3 vessel and left main disease. And at that time they suggested him basically surgery because of the high syntax score of 33, but patient decided as a family, largely because of age, there are not too many comorbid conditions. They decided to go for intervention. Patient came here, Dr. Kinney did the RCA PCI, and we are going to talk about the LAD, left main LAD circumflex today. Very calcific lesions on a good appropriate medical therapy, and we'll just show you that angiogram. We can go to the,
yep. Yeah, so LV is near normal. This is the right coronary artery with the rota, and after rota we did a cutting balloon followed by stenting and then high pressure balloon. So
it's a 3.75.
Excellent.
Yeah, excellent results of the Promus Premier, and this is your left main, and look at the calcium.
Yeah. So you see we didn't inject immediately, lot of calcium, eccentric distal left main lesion extending into mostly ostial circ, but definitely extending into the LAD also. Circ itself after that is okay, and this is the LAD.
Okay, tell us imaging, you wanted to do some imaging testing in this case?
We were debating which imaging we wanted to do. We were ready for OCT, but then once we did this angiogram, if you see, eccentric almost 95%.
I know some disease in the proximal LAD also, with some calcification.
It's essentially 1-1-1 bifurcation.
Yeah.
EKG lead.
And if you see the distal left main, just in this view, eccentric calcium almost subtotal, and because of that we did not we were ready with OCT, but we are not going to do the OCT, and one of the pitfalls of OCT is the same. If you have significant disease, when I am saying significant, more than 95%, and there is no dike clearance, you cannot do OCT, which can give rise to any kind of arrhythmia, especially VFib. So in this case, if you need an imaging, we will have to do intravascular ultrasound.
Right.
And which is okay also, I mean, particularly for the left main, nowadays a lot of data are coming that IVUS adjunct may help to improve overall outcomes, and that is where our plan is today. The use of rotational atherectomy because of such a heavy calcium, and we'll go through various stages that what burr size and so forth shortly, but clearly with a 2-stent technique. And now clearly, as you know, in these kind of cases, the class 1 indication is your heart team discussion, and you calculate the syntax and STS score. STS because of overall outcome after the surgery, but syntax because studies have repeatedly shown now, and they will get a recent update, but overall that if you have a complex coronary anatomy with a high syntax score and patient has a low risk for surgery, means STS of less than 5, and so those patients should go for coronary artery bypass surgery. PCI is inappropriate. But clearly that in the intermediate risk, this patient is 33, just at that border, and more importantly that after the discussion, patient decided not to go for CABG and elected for PCI, so will fall into that category. So this is the case we have, and any point preference?
Yes, Samin, the real question I bet you most of the viewers are going to be thinking is what about the use of either Impella or a balloon pump here?
Yeah, that's another very good point in this particular case, although despite a normal ejection fraction, so that because of the complexity, usually with the normal EF, we try to not put any of these assist devices by even our algorithm, because clearly there's all those assist devices, Impala or balloon pump, will have a higher complication rate, but everything is inside the room. If required, rapidly we can switch and advance these devices.
Second question is, I know you are planning a rotational ablation here. How would a cutting balloon or orbital be in this case?
Well, I think the cutting balloon will be adjunct after rota. You still will need a flextome or angiosculpt, but as far as orbital atherectomy, because it's such a large vessel, so anytime when you think you are going to use a 2O burr, from my point of view, that's not a case for orbital atherectomy. So therefore, this case is the rotational atherectomy. We have 7 French guide catheter, so we can go up to 2 or even 2.15 burr. Of course, this is the kind of case you need to have a step burr approach. You cannot go to the big burr right away, but this is the case which will go to up to 2 or a higher burr, which happens maybe in 5-7% of our rota.
7 French system?
Yes.
Excellent.
I think the most important point here is which vessel you want to burr into.
The circumflex, no?
Yeah.
Just
That's correct.
Yeah, but look at the eccentricity. If you want to go into circumflex, we have opened a 175 burr, that's not the right burr choice. You need to downgrade it. I mean, nothing wrong in trying 175 into the LAD.
Okay.
And then you want to go 2 burr size, or we can do 1
so
burr?
if Nitin Burman wants to do a radial here, what would you tell him, a transradial?
Well, 7 French, although this patient may accommodate, we know that some radials will accommodate 7 French, and I know they talk about the sheathless guide, but we found them very stiff, caused a lot of pain. We go with the routine 7 French sheath. Yes, we had done a handful of cases with the 7 French radial catheters also. So basically we have tried 7 French sheathless guides, but we go with the 7 French sheath and then go with your regular guiding catheters.
I mean, I can just give you my point that this case itself is so complex. We are thinking of using a balloon pump Impella. I would say you're crazy to think that you want to do radial.
Excellent.
Yeah. Okay, the goal here is, you have a tough complex case. We are going to decide how we are going to do the case. You just do those steps 1, 2, 3, 4 and come out without any complication. That should be the goal.
The reason I mentioned transradial here was exactly to steer away from that.
This is not the case that you want to even think of it.
Samin, I believe you've got some valuable updated information on BVS today.
So we will start those 2 points while we are getting the guide ready and IVUS, and we'll interrupt when the IVUS will be ready here. And these are the 2 points I want to discuss. Again, I always want to give a latest of the trial data, and this is right now on the Bioresorbable Vascular Scaffold, BVS, some people calling it BRS, particularly thrombosis, which has come up like 4 papers in last 3 months. And second is the long-term outcome after unprotected left main intervention, the data which have come.
Samin, it is also my understanding that the first topic is being discussed with the FDA very soon.
Today and tomorrow.
So very appropriate.
Yeah, very appropriate, absolutely.
We wish them good luck, and let's see what you have to tell us.
Yeah, I mean, I definitely want to clearly wish the good luck, because we want this technique, this technology available to us, and I'll come back in the end that who are the appropriate cases. Now, basically the concept of having a absorbable stents come from this, I would say, representative slide, which is the slide for many of our long-term DES data slides. So basically showing that even after your 1 year, this is the SPIRIT 3 trial, which compared Texas with Zions V, that after 1 year, about 2% per year there is an event rate in the stent. So question is why? Why there is a 2% event rate in the lesion, not in the vessel. Less vessel, clearly we know various reasons for the vessel, but clearly in the lesion, because of the neoatherosclerosis, new event at follow-up, so various factors lead to this 2% event rate. So what if you have that stent which disappears after 2 years and so this late event may be mitigated. Again, That is the concept which is what is basically drove the whole field of the bioabsorbable stent.
Samin, a quick question has come here. How much is the event rate for a BMS?
The BMS, I would say, will be about after 1 year. They also continued. Even, of course, there is a high restenosis at 1 year, but even after in the BMS studies also up to like 1.4, 1.5%. So even in the BMS and the DES between 1.5 to 2, we have the all-comer resolute trial. The event rate is 1.8%. So comparing our BMS with the even first generation our DES, event rate is about 1.5%. So clearly in the BMS group. So there is always event rate. Now question is this event rate from what? One is could be just same late stent thrombosis, and secondly is the phenomena which we learn now is the neo-atherosclerosis. That basically these vessels on the long term, these stents, they, yeah, okay.
This is what see angiographically we predicted. Even IVUS is not going in.
See that?
There is no way the OCT could have been done in this case.
Yeah.
So see there. I'm just trying to get.
And this is to the LED.
LED. Forget
not
the
to the circ. Yeah. But you can do the IVUS here, just
okay,
this
start
area.
Quickly, because this can give ischemia, because I think the lumen is this is in the LED. You're pulling back.
Yep.
Okay, this is the distal left main. Look at
Very
that.
calcium.
Yeah.
More than 180 degrees is the one makes it a heavy calcium. It's almost 270 degree.
Yeah,
The
we are out
proximal
now.
is okay.
Just a short eccentric lesion. I
But you
think
did
we are
not
good.
cross completely anyway.
No, we did
Now
not.
what are the chances that you can make a turn into the circumflex?
You may
You
need
leave it there and just see if the
I
wire
think
can
you
go.
will need a specialty wire to
No,
make
but
that
let's see if
turn.
this wire if can go, and you can leave this inside.
Why you need into the circle?
No, just can we make or no?
No.
I mean, truly, I always say, if you are heavily calcium, don't do any of this imaging technique because that can make even patient more unstable.
Yeah.
And so.
Some dye.
That's
Yeah,
okay.
hydrating good, right?
Yeah, this may require a venture and other catheters to go into the circumflex. Or maybe even
very
field
sharp and eccentric.
calcium.
Let's do the rota, then we may be able to wire it.
Okay, good, then fine. Okay, so clearly heavily calcific.
All
so
right, there we go.
Good. Okay, that's fine. If it doesn't go further, let's just try.
Okay,
So,
good. You
yeah,
brought
we
it
did.
back.
I moved already. So we are trying now. Let's get the IVUS there and.
Pablo, ready? What's the cross-sectional area of the distal left main? 5.8.
Okay, went through very easily, huh?
Wow.
Wow. Okay,
Okay.
ready, quick.
IVUS. Yeah. Now the circumflex. IVUS.
All right. You see the image beautifully.
Yeah. Here is the calcium is less than 90 degrees arc. Now
Well,
getting
we
about
haven't reached
110.
the main area.
Yeah.
Here.
Now coming across.
There you go.
Yeah, this is the one.
Yeah.
Whole
Oof.
circular calcium, and then get to the left main. So short lesion, but definitely the question is do a 1.75 bar into the LED first, and then decide
But I think this will respond to cutting, no?
the ostial. That may be that may be okay also, and then we do a basically a bigger bar from the left main to the LED for adequate stent expansion after the 1.75.
But you definitely want to do rotational because you are convinced about the extent of the calcification.
Yes, both
Okay.
angiographically and now confirmed on the IVUS.
All right.
Okay, so while
It's surprising though that by angiography it looked as if the calcification would be more towards the ostium of the circumflex, whereas it is much more on the LED.
Balloon?
yeah, that is true, absolutely.
3.5.
So let's go to our presentation,
3.5 flex
and
strength.
this is the question always, that which is the first
4 or 15,
bioresorbable
4 or
vascular
15 height.
scaffold in the world, and the answer is not the absorb. Answer is Tamai. Agaki Tamai, which was first presented in 1996-98, although it's no longer manufactured, but that was the first bioabsorbable vascular scaffold used in the human being. Huh? Yeah, you start to getting the rota, yes. And then now we actually have the absorb, which has come to various trials. The second one, elixir dissolve, which is have the drug eluting novolimus compared to the everolimus on the absorb, is also approved by CE mark, dissolved by some trials have been done. Then the Reva Phantom, which I think Boston Scientific is getting involved with the iodinated tyrosine derivative. The both absorb and dissolve have the PLLA as their polymer. I mean actually the manufacturing the body, and then the sirolimus in the Reva Phantom, and the Biotronic Dreams has the magnesium eluting sirolimus, because remember old magnesium stents was disintegrating earlier, now this one has better kinetics. So, we will be hearing more and more actually the another company in the in India, Merrill has their another bioabsorbable Miras and the bioabsorbable scaffold, which is actually thinner struts, and we will hear more the data about it. So, basically the concept, as I mentioned, that stent disappears, so that really gives the that you give a natural physiological vasomotion to the vessel, particularly important in the younger patients, and show that the after the drug is gone, then your basically the integrity of the stent, and then you have the mass loss of the stent. So, idea there is that at 24-36 months the stent start disintegrating, and of course, there is some issue that maybe 8 to 10, 12 months when you start having a disintegration of the scaffold, can some events occur. So, this is more theoretical, but overall is that ultimately by the Krebs cycle, this PLLA is disintegrated into the carbon monoxide and water, hydrogen, and so. So, that is how basically resorption occurs of the BVS. And does it disappear? I think the consistently the data I have shown now that at 5 years you see just a ghost of the scaffold, and there is no metal compared to which is the metal on the left side, and so. So, therefore, the concept basically is that we have a restoration of the vaso motion and the possibility of the restore more natural vessel function, then the lumen gain, which is the enlargement, because you have continued to have positive remodeling. Then plaque capping also happens, that some of the event which I said neoatherosclerosis, that if you cap with the plaque capping by by the device, so maybe thick cap will prevent many of the future events. And lastly, the plaque regression, that basically the reduction in the plaque area observed at a follow up. So, these are the concepts which have been shown and make sense has shown by various studies, and I think one of them now we are the absorb cohort B just presented a few weeks ago in JAC, that you see after 24 months and so the event rate in the BVS is flat. So, maybe that what we are thinking, that what event rate after not 1 year, maybe 2 years become flat compared to the DES which is on the top. And of course, you can see the lumen enlargement and the stent disappearing on the IVUS as well as an OCT, and of course, the OCT is better to detect those ghosts of the stent scaffold up to 5 years. So, now, everything looks good. So, what about the randomized trials? I mean many of the trials, one of them being absorb 3, which was presented in TCT last year, published in the NIDDM, really shows these are the target lesion failure individual component, absorb in yellow and Zions in blue, and if you can see that event rate in numerically in all the group was slightly higher in the absorb group, but more importantly most of the time it was the non-inferior, but we clearly saw the big signal which was supported by the earlier studies, that you have a device thrombosis of double compared to your DES. So, 0.74 to a 1.5 and so. So, clearly the double the stent of stent thrombosis, and then of course, there is a thick strut. So, it has a less device success because you cannot advance this and so. So, with that note actually Anu is ready to do a rotablation. So, I think we will go now. We have 1.75 bar, and I will come back to our presentation in few minutes.
And if you see, I was able to wire the rota wire directly into the LAD without any problem, and let us just check for the speed. With 175 bar in the distal left main, you probably want to be just above 155.
Good. Okay,
good. So, ACT about 3 130 on Angiomax, patient has been on Plavix and PRU is 180.
And with this age of 80, I think that if they're doing good on clopidogrel, probably will be the best drug in my
Right.
opinion, having a lower bleeding. But although clearly the complex cases, you definitely want to have optimal antiplatelet therapy and you want to be sure that clopidogrel is effective based on the PRU.
So I am just at the ostial left main, do your 3 steps, check.
You want to pull the wire a little bit more?
No, I think you are okay, no?
Yeah, good. I moved that.
Okay, yeah.
Good. So start.
Went through very nicely.
Good. Do one more polish?
Yeah.
Okay.
Anu, you are planning to burr down the circ also, no?
We will see if the wire goes easy right now.
Okay.
We will do that.
We have the fine draw. Good. Okay, we are coming out now.
And the patient tolerated it well.
Yeah, yeah. I mean, he actually use a pacemaker. Blood pressure was 40. Heart rate was
looks good.
40, and we wanted. We have a pacemaker. No, you want to come out or go to the circle?
No, this wire will not go this way. Question is, do you want a bigger burr here? 2.15.
Okay, let's take a picture and see.
Yeah.
And pressure systolic is like
Put a field wire
140,
in there.
diastolic is in the 50s. No change.
Excellent.
Leave it there in case you want.
Samin, you mentioned about the Igaki Tamai stent being the first BVS platform, looking good, although more
Circ.
circ
compromised.
plaque shifting a little bit maybe. I
don't think we should put
remember,
another bar.
you know, all sorts of physicians will make claim who was the first physician to talk more about BVS. I remember I was training a site with the laser angioplasty in 1992, and Marvin Slapian in Phoenix, Arizona, I heard him talk about bioresorbable stents.
Yep.
And each time I meet him, I tell him I don't know where he's working now, but that he was one of the first people I
What
heard.
do you want to do?
We can put this wire and then we the change and do a little PTC of the left main.
No, but are we going to do the work anymore?
No,
Then let's. I think we may be able to wire the circ directly. No.
no, not with the rotor.
No. Okay, just give me a run through. I can go to the circ.
But are we going to use this or no?
No, we're done.
Rota. We are not doing rota for the circ?
No, you want? That's my question.
Oh yeah, rota for the circ, yeah.
Oh.
Yes, rota. No, I think it's a very calcium, and we should definitely do the rotablation of the circumflex
Okay.
also.
You're going to try getting the rotawire
Yeah.
there or
Yeah,
exchange
first
it with?
exchange.
Okay.
This is the case of exchange because rotawire will not have that.
Anu, you had no concern the rotablator wire was in a diagonal instead of the main LED? Doesn't
because we knew that
no
we are
big
just
deal.
going to go to that short
Yeah,
segment.
boss, only prox LED. Even if it's
Okay.
in the diag, that's the thing. Don't get waste time. Try to go to the main vessel. There's no concern there. So,
That's such a big vessel, right?
I mean, if you are going to do further down, then you know you have to be in the main vessel. Okay, go into the. That's in the OM.
Yeah, you want to
Go
to
straight.
the main?
Yeah. Good. Now what you need to do is take the rotawire and go here.
Right.
And the
I
same,
think rotawire would have gone.
yeah. Of course, the same wire, no?
Yeah.
Now only
No.
question was that could we
Could we have used that
we may have
correctly, yeah.
You seen our technique where we will leave the burr in the guide and on the dyna we will take the tip of the rotawire and go to the other branch. We have
Right.
shown that couple of times when you are doing LED diagonal. We could have tried that.
But in this case, I felt that will be a little too because of the angulation, and then rotawire clearly we know is not that user friendly,
Just okay, leave it.
And, the
and
plan
they are
is
making
to,
some changes in the rotawire.
Right.
They had a good one, elite, which had to be with the a callback or voluntary recall, whatever the terminology Boston Scientific uses, make them happy, but the wire is no longer available. That's basically the matter is.
So you'll go back with the 175 there?
Yeah, same.
Okay.
This now is a tighter lesion and angulated
Right.
cup.
Right.
Definitely don't even think of a bigger burr into the circle.
Yeah. The question was even should we
Even
go with
smaller?
a
Smaller,
Yeah.
yeah.
That's what I was.
Yeah.
Okay.
I mean, we'll see how the burr is behaving. If we think it's we are having trouble in making a turn, then you definitely go downsize. Have the 1.15 burr ready.
What was the speed you had used?
150, about 155 for the.
And we know that angulated lesion, Rotac does the wire bias, which is okay, as long as you are not having the advance slowly, because that basically represents that you have cut the interelastic lamina, which will expand your stent and the subsequent vessel much easier.
So, Samin, let's say somebody who's trying to be extra cautious and would want to put in some support device. What would be the choice?
Balloon pump.
This one is balloon pump.
Balloon pump. When you have normal LV function, go for balloon pump.
Okay.
As a prophylactic.
Yeah.
If you need to do a bailout, then of course you use Impala.
No, even then, I think in this particular case, bailout,
One second, let's
if
keep
you
the
are in
wires
the
open.
emergency setting.
Yeah.
Oh, small branch. again.
Smaller access sheath and the cost.
Yes,
Yeah,
yes.
that's it.
And faster. No matter what, it's faster. It's in a very small branch.
Yeah, we're going to pull
back.
it as soon as we go there.
No, rota wire in a small branch could give trouble. Okay. Okay, good.
That's fine.
No, you may not have the wire purchased now.
Will be okay.
Are you pulling? Guide is moving out. Okay.
Good.
Same thing, 3 steps. We are at 155. That's the speed we have. Some die.
Okay.
The wire
We were
curl,
just
don't
checking
waste time.
Right,
So we
yeah.
keep it there. Yeah. Good.
I'm holding the guide.
4 of flextome and 3.5 angiosculp.
No,
Right?
flextome. No, I have a 3.5 flextome
Okay.
and a 4 high pressure balloon.
Okay, fine.
Lot of wire bias there, no? Okay, went through there.
See that it just
Yeah.
went in easy, didn't make a jump, so we are good. He's
Did a little
actually
more.
tolerating okay.
And I'm going to change the wire position.
Yeah.
Yeah. Good. I'm chinning it. Round it further. Good.
I think we are good, we'll come out.
Yep.
Okay, get us both the wires. There's some STs, you think?
No, you always have this J point elevation. Okay, we have done a 1.75 burr in both, and let's take a picture.
I think looks good. We should just go for PTCA and stent.
Wow,
Yeah.
beautiful.
Very
Look at
nice,
that. This is tells you that better than
Much better
your wire
expansion
bias
on
worked
this.
on your favor,
Right.
making a bigger lumen than 1.75 bar. Okay, now while Anu is going to do now the wiring and do a little pre-dilatation for the two-stent approach.
Before that, Samin, a quick question here. So you don't think it needs further cutting here? You'll proceed.
No, we'll do a
We
cutting.
will
You will,
definitely. We will do a cutting here now, both the branches. We'll do cutting, and then we are going to decide on the stent strategy. Since it is distal left main,
Two-stent approach.
no, I know. But you want to V-stent, or we just come do the V-stent, or you want to do mini crush?
A big vessel, we need to do a nitro. I mean, you can put two stents here. I mean, with the
I think,
SKS
if at all
technique.
they come back,
Yeah.
then we have problem.
Yep, SKS will be
No.
okay.
Let's do mini crush.
Okay, or the mini crush. Good. So meanwhile, while the lesion being prepared with the atherectomy of the flextome and maybe some angiosculp, we go back to the some of the data on this Bioresorbable scaffold particularly the first paper from in the Lancet by Greg Stone's group, showing that 4 trials of the Absorb 2-3 China, Absorb China and Absorb Japan, showing overall BVS in red and cobalt chromium EES in green. And you can see here overall event rate is exactly the same, I mean, or numerically again in the favor of cobalt chromium, but not significant. And the more important, the event early event are higher in the BVS group, and of course the stent thrombosis, which was just the double 0.6 versus 1.3 and with a sig p value of 0.08. Other points are almost identical, slightly higher MI rate also with the absorbed stent, and because of thicker struts and the periprocedural MI has given rise to these ischemic endpoints. So predictors of stent or device thrombosis were diabetes and small vessel, and this is where keep coming back, and so that BVS yes, but more importantly they had a higher event rate, higher stent thrombosis in the vessel which are less than 2.5 or 2.25. That's where the whole problem starts in these cases, and these are the various predictors of subsequent outcome and so on and so forth. So the overall BVS really has very little positive. Overall EES works in most or predicts better outcome in majority of the situation. The second paper was from Lipinski and Dr. Waxman group, scaffold thrombosis after percutaneous intervention with absorbed vascular scaffold. They took 26 studies with 10,000 plus patients, 8351 BVS, 2159 DES with a 6 plus minus 5 months follow up. So average was about like 8 to 9 months follow up in these cases, and basically came up with a various individual forest plot of the MACE and other events. So death actually trended to be lower with the BVS, and remember that it's a contradiction that you have a little higher stent thrombosis, but how can death be lower? I give the analogy, same thing what happened in the Angiomax group bivalent trials, that you have higher stent thrombosis, but you have a lower subsequent mortality, and partly because if you have a thrombosis in the hospital, it's a less lethal and you can take care of it. And then of course Mackey was not different, as you see here. MI definitely the more MI in the BVS group, and the tower as you can see the TVR is just identical. Now more important, and that's the concern, is the scaffold thrombosis. Clearly everolimus eluting stent has a 50% lower the device thrombosis, definite or probable, compared to compared to a BVS, and this is actually more acutely and subacute, and after 1 month actually the difference really becomes less. And the third paper, so basically they basically concluded that patients undergoing PCI with the BVS had increased definite and probable stent thrombosis and MI during follow-up compared with the DES. So clearly this is the early experience, taken all the studies together, that is what we learned. So, and this is now all the trials now having the stent thrombosis. It turns out to be that if you take all of them, will be somewhere between 2.5 to 3% scaffold thrombosis, which we know is much higher than what happens with the DES, which is about 0.5% at present. So then the issue was that can you change it, and this is basically the 4 centers study by that scaffold thrombosis. What can you do? It occurs early, as I mentioned, and early can be taken care without causing the death to these patients. And predictors is still again the small vessel osteal lesions and so on and so forth. But more importantly, that what they decided, the 4 investigators change after the early experience of 2012 and 2013. In 2014 they changed the implantation strategy. So BVS specific protocol. And what is the BVS specific protocol? That they have a pre-dilatation with 1:1 high pressure, BVS implantation only if the lesion opened up, even you require use a cutting balloon or rotablation in some cases, and then deploy the BVS at 12 atmosphere, and then post dilate 0.25 or 0.5 higher at 16 to 20 atmosphere. So all these steps, what really they did, they brought down the 3% scaffold thrombosis rate to a less than 1%. So 3% went down to 1%, and we know 1% is just like our drug-eluting stent. So therefore, basically it showed that impact that yes, you do a better technique, you will decrease the scaffold thrombosis. Now, why this is all happening? Because to me, very simple mechanism. A mechanism is the size of the strut of the bioresorbable stent, which is 150 micron, almost double what we have for the synergy, which is 74. So that's where the whole issue. So you have a thicker strut. So even if it gets absorbed, cause more inflammation is acutely, difficult endothelization, and of course causing more thrombosis. So that what we felt that maybe with the BVS you have a lower depth rate, which is not correct, because it takes 2 to 3 years to absorb. So really you need to continue longer, and this actually have been shown by many the recent paper in the circulation cardiovascular intervention cases of subacute thrombosis with the overlap area, the malapproached BVS area, and of course when dual antiplatelet therapy was stopped and you have malapproached stent creating the thrombosis. So basically the overall analysis was that we have the BVS scaffold thrombosis largely the technique related, and therefore what you should do, and this is where hopefully we get the device approved, and these I have put it here. There should be a full lesion preparation with pre-dilatation, with bringing the lesion to less than 30%. Before you put a scaffold, you may use a scoring balloon, cutting balloon, or rotablation for the calcific lesions. Then careful size scaffold 1 to 1, and of course cover the area, and then you bring it to a 10 to 12 atmosphere. Avoid the much overlap of the scaffold, maybe a 1 or 2 strut, the point to point, which is the dot on the proximal end of the scaffold, and then essential routine post dilate with a high pressure to 20 atmosphere minimum with a non-compliant balloon. And I would say liberal use of imaging, especially the OCT, is highly recommended for scaffold optimization. So these, in my opinion, are the 4 steps which we are going to deploy once we have the approval of the BVS. Now, one really is another important point which they are looking into is that kind of which you can say cosmetic, is that because the BVS gets absorbed, so the maybe patient will have a less chest pain. And the Absorb 4 trial is looking into the 2000 patients, non-inferiority to the Giants, and particularly in terms of the reflex testing as well as angina gradings. Hopefully the absorbed patients will have a less angina, although earlier trials of the Absorb 3 did not show that. So these are the few trials which are ongoing at present. One of them very important one being the Absorb 4, and the second is the Prospect Absorb, where the lesion high risk plaque are being sealed by the absorbed stent, although they are non-obstructive but high risk compared to a medical therapy. So this is all we will know in coming time, which is the best, what is the best treatment or best technique, and where this device will fit in. So therefore, who are the ideal candidate for the absorb? I would say proximal lesions, vessel size between 3 to 3.75, because the stent is only 2.5 to 3.5. So don't put into the 4 millimeter vessel, you may not be able to expand it. Lesion length is shorter, maybe overlap, but we got 28 millimeter length is only, so little overlap. Young patients and patients with acute coronary syndrome which have a delayed endothelization of the DES, and of course maybe the DES ISR, the trial ongoing at present, but maybe once your DES ISR absorbed BVS will make a better sense in those cases. IVS and OCT is highly recommended in early cases to understand the mechanism of expansion and full apposition, and of course continue in the complex cases. So quickly, while we are getting ready, Dr. Kini has done the dilatation of both the branches of the circumflex and the left main to circ and left main to LED. I just want to quickly finish this left main long-term data, which are we will be done quickly. These are the few trials which have come. Where? Perfect. Yeah. So therefore, this is basically the Lehman's trial, the 10-year follow-up, showing that there is a ejection fraction is still better in the PCI group compared to the CABG group, which is at the bottom, as you can see there. So clearly that EF goes down after 1 year in both that study. Both these patients all only 50 plus, but clearly the advantage of the PCI or DES remained with the first generation. And these are the individual endpoint of the major adverse endpoints as shown here. So now basically it seems to be that yes, in selected cases you can do PCI, and this is what our guidelines are. We know that data from the syntax, which is the Mackie up to 5 years, that overall actually the patient did okay compared to a multi-vessel disease. The left main, the Mackie was non-significantly different, and largely because that when your syntax score was 32 or less, as you see here, lower mortality with the PCI compared to the CABG. And of course, with the once you go to higher one, you have higher mortality with the PCI. So that led to the formulation of the Excel trial, and these are the various left main PCI outcome optimization. I have put it here, and particularly the adequate lesion preparation and IVUS is important. So the Excel trial of the 1800 patients will be presented in the TCT later this year in the syntax score of less than 32. So really, these two trials, Noble with the Biolimus and Excel, will really answer the role of this device technique, the updated DES PCI in the future. Okay, now we can come back to the angiogram. Yeah,
looks
tell us
very
quickly what you
nice.
did.
Yeah, so
Ready
we
for
did a
the step.
3-5 cutting balloon to this
On
both areas. You see there, this is where we left after rota, 3-5 cutting balloon. You see
very
that?
nice,
You see?
Yeah,
Just a little
it's
staining.
a very small staining on the top.
I mean, just at the level of the LAD, actually you see it right here also, but a little bit gets worse as soon as I do the cutting balloon. There's, if you can appreciate, there's a little staining.
Yes, we do.
Huh?
Yeah.
Yeah.
Yeah, so immediately I went back and just put you know, he tolerated the balloon. This is a 3-5 crack it. No, I didn't stop the
Then
angiomax.
continue.
Yeah, we just did this. It could be because, you know, the eccentric calcium there, and here also you see deep intimal calcium, which is also eccentric in the LAD.
Good.
So we are done with all that.
Was that a prolonged inflation?
Yeah,
or
yeah.
just
I left it for just for a minute, no more than that.
Disappeared. Yeah.
yeah, completely
It's
gone.
Now we have to
we
put
didn't stop angiomax. Right, this is where we are. I think if we are going to do the mini crush, we will get a 4.0 into the circ, 4.016 into the circ.
Good.
And what you want into the LAD, 4.0 or 3.5? 3.5.
3.5 for 28.
Anun, you don't think it needs a little longer in the circ?
Yeah, circ, yeah, 24.
21?
Yeah.
No,
24.
not 24, 20.
20 maybe, yeah.
20,
20,
okay,
20.
okay.
24 will go near the
and
OM, we don't
28
want it.
and 3.5, 28 in the LED.
Samin, a quick a couple of questions with your very, very elegant presentation, I think, which has become so pertinent considering the events about the approval of the BVS which are going to be happening. You mentioned the 4 kind of recommended steps for BVS.
Yes.
That's exactly what you do for most of your complex lesions, no?
Yeah, I mean, but what basically the
No,
point?
in particular you, because
Let's
that
go
is
to
what
the
I was thinking we've been emphasizing routinely.
There are types of bifurcation.
Huh? Yeah, no, but we're not saying. Yeah, no, but that is absolutely correct. That BVS or no BVS, the only thing is that your DES, because of their better healing, is forgiving.
Right.
BVS is not forgiving. That's the key. Your unexpanded DES may be okay, but your unexpanded BVS will cause a stent thrombosis.
Excellent.
That's the point.
Wonderful point.
Yeah. So therefore, if you could not expand it, there's no reason for you to put BVS, put a DES.
Right.
Nothing wrong in that.
Got it.
And hopefully we'll have the data by that time with ISR that those cases may be okay.
But your most significant take-home message from the presentation you made appeared to be lesion preparation.
Absolutely, lesion preparation, and don't be afraid to post-dilate. You know, in the past, there were people used to worry about that scaffold will rupture, will disintegrate if you do a high pressure. That is not correct. You do a 1:1, maybe 0.25 bigger. You go to a very high pressure, that's okay. If you go 1 millimeter higher and go to high pressure, of course, you will disintegrate circumflex first.
What are some of the present thoughts
Who is that?
that the 150 micron should be reduced to how much?
100.
100.
The next generation, yes, yeah. The Miras and the newer generation of the absorbed by the BVS by the Abbott is around 100 to I think it's 110 micron. Yeah.
I think going back to the point here, Samir, you asked whether why we selected rotational atherectomy and not orbital atherectomy. I think we can make a point here. If you see this, can you see the angiogram I have just?
Yes, we can.
Okay, so you see how eccentric the lesion is?
Very, yeah.
Where in the distal left main and that extending into the circ. And I think in this kind of cases, actually we did with the OCT study, we did publish it in CCI, that if you have calcium arc, which also we saw it in the IVUS, two quadrants, which here we showed is only two quadrants, that when you are doing orbital atherectomy, your wire bias and what we can say more of wire bias itself is higher in this kind of situation. That may be one reason which we do not want to do orbital atherectomy. And if you see here, after we did rota, which we knew we will have wire bias in the circ, if you see how we did the rota into the circ, this is where we are. We did have smooth rota into the circ. Absolutely no wire bias here. I think that is one important point for the selection of atherectomy, why you wanted here we wanted rotational atherectomy versus orbital atherectomy.
I mean, clearly the angulated lesion where the wire bias is in orbital atherectomy has a more chance, in my opinion, to cause perforation. Good. Let's get the other one. Yep.
And going to that techniques, I think what kind of stenting, two stent technique is definite here, because it's distal left main, large two branches, and I think three kind of technique that we can think, not three, probably five here.
Yeah. You
could do a V stent, and if your carina is slightly longer, SKS, or otherwise you could do a culotte, DK crush, or the mini micro crush. That's a mini micro crush is what we are doing in this particular case. You will see a 4020 which has gone into the circ, and then we have a 3528 that's going from the distal left main into the LAD.
And what balloons you want post?
Post, oh, you want to go to the circ with what? 2512 new balloon?
No, 3012.
30 may go or may not?
Yeah, 30 will go. Okay, good. Let's take a picture.
Okay. We see.
Come back a little
16.
with the circ, or?
That's okay.
No, circ 16 would have been okay.
No, that's okay. It's still okay. You can pull back 1 millimeter. No, circ you have to pull back 1 millimeter, and then we are
Which is
ready
circ?
to go.
Who has circ?
This is the circ. This is the circ. Yeah. Pull back 1 millimeter, and we are okay to deploy. This is fine. Ready?
Okay.
I'm going up. Okay, circ is we are going. It is the 4020.
A little bit too much in the left main, but that's okay.
Expanded very nicely there.
Okay, down.
40. Get to inflation. Get a 4 non-compliant balloon, and okay. Get a, and then get a 3.5 15 also high pressure.
Get us a 2512 prick, yeah. First to cross.
Okay. Now the same as a technique wise, you have to remove both the wire and the stent as long as the distal area is good.
What do you think? The stent is too much?
Yeah.
In the left main?
That's all right.
Yeah.
Circ
Okay.
is looking very good.
Okay. We took out the wire balloon and go up in the LED now.
Go.
Right.
Yeah.
Yeah.
He is tolerating very well, and you see my guide is out.
Good.
Pressure is 120.
He's also tolerating well because you have taken some very prudent measures. This is
Throw this way. Yeah.
and you just mentioned how you've backed off with the guide there. I think if the guide had been left there, you'd been yelling out for a balloon pump. Samin, just to also excellent review you made today, but I would urge our viewers to look at, there's a beautiful editorial by Dr. Michael Mack and Dr. David Holmes in JACC Intervention, where both of them also relate to another important BVS advancement, that patients several years after having BVS still are excellent targets
Okay,
for
ready?
surgery.
Yes, that definitely the another very big point. All
looks
right.
wonderful, looks excellent.
So take this one out and let's recross.
So what would you post expand with?
No, right now we need to recross. For recross, you will go with the compliant, maybe a 2025 balloon first.
No, left
okay,
I can
25.
You have
but
40.
25.
You have 40 new.
Okay.
Cross first. When the left main will go.
It's not a question of left main, it's a question of the
5. Okay.
crush we have there.
Let's cross. Okay. That's
What
fine.
size are you using for that?
Yeah, just to cross first the
we
2.5
cross.
compliant, and then we'll use a 4.0 in the left main to LAD. I mean circumflex. I think you need to make a new tip of the wire.
Okay. Just when you wanted a different wire, here it goes.
Yeah.
Okay, somehow it keeps going to the OM.
Yeah, that's fine.
No,
Okay,
we'll leave it
much
in the
better
OM.
there.
It has the memory, the tip has the memory to go back to the same branch.
How significant do you think BVS will emerge for DES in-stent restenosis?
I think the conceptually it makes big sense. But the idea there, because additional metal layer is going to decrease the overall lumen.
Okay, 4.0, and how much you want in the LED? 3.5?
3.5. Yeah, we have 3.5.
Anu, who's the
Down.
fellow scrubbed in with you today?
Down, I have a Nishta,
Yeah.
who is our female interventional fellow, and I have Mani Kumar.
Excellent.
Yeah.
Two of
Nice
them.
meeting both of them.
And key is in this kind of once you have done the crush, you and large vessel, you as you see the wire was little distal part of the stent strut. So that's what you want to do, because that's where you'll open better. 4.0. Yeah. So now we are done 4.0 into the left main and circumflex, and then we'll use the 3.5 in the LED.
How would you follow up this patient?
Now this patient usually that of course I have in my that optimization of the left main is that complex cases, particularly when you think there is another option, that let them come back for 6-month angiogram, which is not a routine now, but I still propagate advice, and I do it many of these cases. But in this particular case, I think it will be reasonable to follow him by bringing, because knowing that his age of 80, if it's asymptomatic, that we just follow him clinically, and routinely we do about 9 months later some kind of a stress test, whether pharmacological or exercise.
So you presented data today of left main 10-year follow-up.
Yes.
How many of those do you think you've had? 10 year?
we did remember the first left main case.
Right.
I did actually in 1996, but more important, I did in the symposium, live symposium, 2 left main in our first one in 1998. So that was official. We made in front of the faculty of 14 faculty.
That was
and
only 18 years ago.
18 years ago.
Okay, go.
Okay. You open the circ first. Go. You have to be careful with the LED high pressures.
Yeah.
Open nicely.
How high are you there?
14.
14, 14. Go 14.
Okay, down here EKG changes.
Yeah.
Now.
Now he is developing actually the pacemaker, pace rhythm, right?
Yeah.
Okay. Good. Let me go to LED now.
And once again, you've taken the guide out.
Yeah.
This is your old 3.5. 16
Down.
is good. You want to go a little further on this?
I'll go further.
Yeah.
And then you kiss and out.
Yep. Yeah, this is the one.
No, I always had trouble getting anything into this LED there. You know what?
I'm going up now.
No. Let me take the 4.0 inside.
Okay. Many times when these 2 balloons have trouble, you advance, make a room, and go a little pressure. Let me go low pressure. So then it will align it, because this is angulated proximal LED. 12.
Down.
Yeah. It already moved further.
So the team here in the control room is telling me that you've already started registration for your meeting?
Yes.
Okay,
Yeah.
good.
All right.
It started, and the agenda is available, and we just keep working on that.
So how much is there going to be almost equal emphasis on structural heart as well as coronary?
Yeah. No, well, I mean, this one is more still coronary. We had told
Excellent,
16
yeah.
cases, of which the 3 are tower, 1 alcohol septal ablation, and 12 coronaries. So that's what we'll have. Good. Going up.
Wonderful.
Yes, no.
Yeah. 10 atmosphere only.
Yeah.
Good. So
LED
now we're
go
doing the
less?
kissing. Huh?
LED go less.
Yeah. LED is 10. You can go 12. Good.
How high are you there?
Yeah, 12 in the circ and 10 in the LED.
Okay.
Down.
Good. So that was just the pace rhythm.
So, I mean, Anu was telling me that in the last few weeks you've done live transmissions into 4 or 5 very large major meetings.
Yep.
That looks to be getting
Ready?
more and more frequent.
That is correct, with the CRT, India Live, and where was the
No, we
And
went to
Turkey.
Turkey.
And Turkey.
Turkey
Okay.
Society? Yeah.
Looks beautiful there.
Beautiful. Good.
And
So
the
let's-
LED, that little haziness is all gone. A
Gone.
beautiful lumen.
Okay. So we can take that we can just complete our this is the excellent results. Let's come back to our take home messages. That is BVS thrombosis and unprotected left main PCI. That the first generation BVS, and that's the statement. Pacemaker out. The first generation BVS comparing with 3rd to 5th generation best DS technology have shown non-inferior MACE endpoints except for higher scaffold thrombosis, which we call now not ST, they are calling it capital S, small c and T. So SCT is scaffold thrombosis. Then numerous procedural optimization techniques have shown to lower the scaffold thrombosis rates and are essential in BVS implantation. Imaging may play a major role in improving patient-centered outcome after BVS, especially after 2 to 3 years, because that's the time you then want to start taking off them of antiplatelet therapy. Then the recent trials of DES and CABG in unprotected left main have shown equivalent long-term outcomes in low to intermediate lesion complexity cases, syntax score of 33 less than 33, but still has ACC class 2A or 2B indication. Remember 2A if they are high surgical risk, 2B if they are routine. Excel trial in these unprotected left main group has a chance, if PCI is equivalent to CABG at 3 years, to change it to a class 1. So that is what we are hoping, that by the year end we have a good result, so that it become class 1 in the syntax score of less than 33. So question 3 is, following statement is true for the BVS versus DES trials. BVS has lower MI versus DES. BVS has higher late thrombosis. BVS has higher acute and subacute thrombosis versus DES. BVS has higher mortality versus DES, and BVS has higher TLR, TVR versus DES, and we have spoken about all these points. Second question, following BVS implantation techniques have shown to improve overall outcomes, high pressure post dilatation, aggressive lesion preparation, OCTI was used, prolonging DAP, and all of the above. And the third question is long-term follow-up of the Lehman's trial comparing DES PCI to CABG have shown the following: significantly lower mortality with PCI, significantly higher MI rates with PCI, significantly higher overall MACE rates with PCI, higher LVEF improvement after PCI, and no difference in any of the endpoints. And we have spoken about that, and with that we conclude our today's live webcast case number 81.
Anu, I want you to provide a quick take-home summary, but before you do that, I must make an observation. It truly is a tribute to your superb skills that such an extraordinarily difficult case you made it look so routine.
Thank you.
Of course.
I think that
Really, I'm telling you, many people would genuinely freak out in dealing particularly with the angulation and the ostium of the circumflex.
Yeah.
Beautifully done rotational ablation as well as the entire case.
Thank you. I think it just goes to say that when I just said that we decided this is what we are going to do, and we just you have to just stick to the plan, and of course if there is any untoward effect, you need to just be ready if something goes wrong, how to take care of it. Going back to just the take home messages, I think important 3 things I can tell you when it comes to imaging, that you saw how tight the lesion was. We were all ready with the OCT, but just looking at the lesion we decided you cannot do OCT, absolutely no in this case, should go to IVUS because that is very important learning in this particular case. And second, once you saw that there was so much calcium, decide on atherectomy, and I think I made my point why we selected rotational atherectomy and not orbital atherectomy in this particular case. And third is the same, distal left main, large vessel, you have to do 2-stent technique, and we have gone over the 2-stent technique, which could have been a V-stent technique. Here would really be SKS. That means you will have 2 stents coming all the way to the mid part of the left main. Otherwise your DK crush or culotte, these 3 probably will be the choice if you ask other people, but what we showed you is the mini crush technique which we showed. I think what is important with the technique which would be the culotte, the DK crush or the mini crush technique that we just showed, that if ever they come back with restenosis usually see the restenosis of the circ, just the ostial circ, it is easier to re-intervene compared to if you have a V stent or SKS stent with this newer generation stent technology. I think these are the points that I wanted to make. Other than that, I think you can focus on our fellows, whom I think you probably asked the question, who are the fellows with you,
yes,
seeing how smooth it is going, and they are now in their 8th month of their training and all ready to do complex cases. And how we do at this stage, they almost doing most of the complex cases with the attending myself or Dr. Sharma, besides them most part of these cases by themselves. So that is why you see that they are into that groove and everything is going smooth. They know how our thinking is going, and they are having the devices ready as the case goes on.
I wish them well. Anu, great case. Samin, final words from you?
Yeah, just to completing the fellowship trend, now we actually have 12 fellows, of which 8 are our regular interventional fellows. Then 1 to 2 we have hybrid fellow, we call them, for 2 years of training, cath research first year and then intervention next year. Then we made a dedicated structural heart disease fellow, and then lastly the endovascular fellow. So the total 12.
Fantastic.
So we have a good army, a little more than a football team, 11. So the bunch is a pinch hitter.
If it was cricket, I would call you the 12th man.
12th man, that's
all
in
right,
every way.
Samin,
Yeah.
excellent case. Congratulations, Anu, to you and to your team. We end this useful case, and we'll see you during the next transmission on April the 19th.